Hello and welcome to another episode of This Week in Hearing. I'm your host, Brian Taylor. And this week, our topic is cochlear implants and the hearing healthcare professional's relationship with the cochlear implant surgeon and the broader otolaryngology community. And joining us today is Dr. Kevin Zhan, who's the assistant professor of otolaryngology and director of the Northwestern Medicine Cochlear Implant Program, which is based in Chicago. So, welcome to This Week in Hearing, Dr. Zhan. It's great to have you.
Thank you so much for having me. It's a real privilege to be here and talk to you.
Well, we're lucky to have you on our show this week. I think my first question before we talk about um, cochlear implants in general is if you could give us an idea about your training, your experience, how you got involved in cochlear implants.
Yeah, sure. So I went to medical school at the University of Virginia, and then I did a research fellowship at the Medical University of South Carolina. I did my residency training at Ohio State University, the Ohio State University in Columbus, and really it was there where I started to really start to feel connection towards otology, neurotology, and just kind of how rewarding taking care of patients with hearing losses can be. And then I did a fellowship in otology, neurotology at WashU in St. Louis for 2 years. And then now I'm here at Northwestern. And I also practice at Lurie Children's Hospital too.
Excellent. And tell us about your experience with cochlear implants.
Yeah. So it's something that I'm really passionate about, cochlear implantation. I remember early on when I was an intern in residency, I remember meeting a young girl in the peds clinic, and I had no idea why she was there. I was just sort of interviewing her, and I walked out of there asking the nurses like, why is she seeing us today? And she was just so lively. She was very, she talked about her school, and she was a fun person to talk to. And the nurses told me she was there to fill out her disability paperwork. And I remember thinking, what on earth? Like, what disability does she have? And she said, and then, I come to find out later on that she had been implanted with cochlear implants while she was pretty young. So she had developed normal speech and language. And it was wonderful. And I became really intrigued early on. And I'm very grateful to have mentors in residency and fellowship that are also very passionate about cochlear implantation. And so it's something that I've just sort of throughout my career, early on, that I've been really, really interested in, but also just a whole gamut of, otology, neurotology, and everything else in taking care of ear problems, essentially. So,
Well, let's talk a little bit about the relationship process between um, cochlear implant surgeons like yourself and the larger hearing healthcare community. I guess one question I have is what sorts of activities do you do in the community to try to build relationships with hearing care professionals?
yeah, I think it starts at all levels. I'm just upon about getting to about a year and a half, to almost 2 years into practice. And so I've really tried to connect with people on multiple different levels, even as early on as really trying to get our Northwestern University audiology students engaged and giving them some lectures, as well as having them in my clinic and in the operating room to get them excited about what it is that we do. To also just go to local society meetings for audiology and hearing care providers, networking there. I've done plenty of sort of direct outreach, messaging people and using industry connections as well. Really help, um, uh, working with industry to build connections as well. For cochlear implants, but also really just for hearing care of all kinds, right? I mean, while cochlear implants are certainly a big part of what I do, but really trying to take care of patients of all kinds that have hearing problems is the main reason why I do this. And then even networking through industry I talked about, and then also sometimes even on social media and LinkedIn, people have connected with people as well. And so I think just sort of the um, just trying to outreach on numerous different levels.
Excellent. One question I'm kind of curious about is I like to kind of let's focus on cochlear implants in the adult population. Okay. What's your experience been as far as the process of referrals from audiologists and hearing instrument specialists to your clinic for possible cochlear implant candidates?
Yeah, it's something that I rely entirely upon, right? And so I think when we look at a lot of reasons why not enough cochlear implants are being performed in this country. In the Chicagoland area alone, there are estimated about 30,000 candidates, right? So that's an enormous number, and that's a pretty conservative measure as well. And so it's really incumbent upon clinics to create these connections with hearing care providers in the community, right? Because they're the ones taking care of all these hearing loss patients. And so it's important for us to network and to work with each other and sort of get to know each other so that we can deliver the best care possible. I mean, I would say at least half right now of all of my cochlear implant referrals are coming from the community. So audiologists, hearing care specialists, or hearing disorders specialists. And it just takes finding the right people and people that are motivated to help their patients, and they'll make those referrals. So it's been a wonderful relationship so far.
Uh, that reminds me, can you remind our viewers, uh, what's the criteria for somebody, an adult, uh, what's the criteria for them to maybe to have to be a considered a to go through the process of cochlear implant evaluation?
Yeah. So there's a couple of different referral criteria, sort of mnemonics out there. I think to speak very broadly, it's important for everybody to remember that really cochlear implant referral candidacy has changed dramatically in the last 5 years. I think one of the big ones is the fact that the FDA now approves a single-sided deafness as an indication for cochlear implantation. So patients, with that had a sudden hearing loss in one ear, or even patients that have in the past have non-growing vestibular schwannomas, we would never consider, or it would be difficult to get them to be approved for cochlear implantation. But now we're having those conversations. We're finding that we're finding a lot of success with implanting these patients. So that's one sort of expanded criteria on that. But specifically for your question, I think what you're asking is audiometric criteria in that ear itself. And I would say, a very common one is the 60/60 criteria, which is if the ear if the ear in question, if the pure tone average is greater than 60 decibels and the word recognition scores are below 60% in that ear, then that's somebody that might be a cochlear implant candidate. Some other clinics use even simpler criteria, just simply less than 50% word recognition score on an audiogram as possible referral criteria. These aren't perfect, they're not 100% sensitive nor 100% specific, but they're a good starting point. But I would say if you have a patient, if you're a hearing care provider, if you have a patient who you fit appropriately with a hearing aid, and they're still not getting a lot of good clarity and they're still struggling with their hearing aids, then that's the demographic right there of who we should be thinking about for a cochlear implant. When it comes to single-sided deafness, somebody who's already tried a cross hearing aid and they're still looking for another option potentially, those are also very easy referrals to consider for referring to see if they're a candidate for a cochlear implant.
That's good to know. So let's take it to the next step then. Let's say that a hearing care provider is working with a patient that you just described that meets this criteria for referral. Um, Talk to us about that process of how they should interact with you or one of your colleagues.
Yeah. I think this is going to be well well, I can certainly answer for me specifically, and our colleagues. A lot of the providers in the community have my cell phone number. They have my email. They know, especially once they've gotten permission from their patients, they know they can reach out to me with their contact information, and I can have our team schedule them so that it's a little bit easier on that patient. They don't have to worry about calling in and being told that it might be 6 to 7 months from now or something like that, something crazy like that, that they can be seen, was simply not true. So I think it depends on which clinic you're trying to reach, but I know that there are certain um, having trying to navigate. I think a lot of large health systems, you might be told it might be a really really long time from now before you can be seen, and sometimes you can even be scheduled inappropriately. So that's why I think the personal connection, those professional connections are so important because it's not hard for me to add on a patient to my clinic, especially when they've come in with an audiogram, for example, from a hearing care provider. It's very, very easy actually to do that. And so, So I think that's one of the biggest frustrations for referring providers, audiologists, hearing care professionals, because they're like, all right, well, go see an ENT, and then their patient's told it's going to be, you know, half a year before they can be seen for, even if it's a sudden hearing loss or something like that, God forbid, right? So I think it's important for the people I work with. They all know they have my direct contact information, so that if they need somebody to be seen, urgently, like a sudden hearing loss or a vestibular schwannoma or something like that, or they can get in touch with me fairly quickly. So.
Are you talking about audiologists that are within the Northwestern system, or are you talking about audiologists just in the general Chicagoland area that would know you?
In the Chicagoland area, I mean, all the audiologists here, regardless of what system they're in, I try to make it, I try to be as accessible as possible.
That's from
Um,
that's what I wanna talk to you about is
yeah.
how what have you done to make yourself more accessible, I guess, is the question.
I mean, I think it's those things, right? I think, it's, and first of all, yeah, just being available, sharing my email information and cell phone information. I think I feel very comfortable doing that. And I think our the providers I work with really appreciate that. They can get in touch with me, and if they have questions, and whether this person needs to be seen or not, they can always ask, and and so that I can just be, a resource for them, right? That, this is, of course, some of what I do is with cochlear implantation, but obviously there's a whole bunch of other things that can affect their patients: severely impacted wax, asymmetrical hearing loss, needing, medical clearance. Those are all things that if they can get their patients seen quicker, right, then they can go back to those providers for their hearing amplification if indicated, so that those patients can be taken care of better and quicker, right? So I think there's all these enormous barriers when it comes to large health systems and sometimes even smaller clinics too. But there are ways around it, and to navigate, those patients in much quicker than if they were to do it themselves.
It sounds like you made it a point of emphasis that, you're reaching out to the hearing care community, the audiology community. Like, have you spoken at meetings, or is this mainly through social media? I'm just kinda curious to know how you've raised
Yeah.
awareness about your own practice.
So in the Chicagoland area, especially being a new provider, in a very saturated market, one of the I found out very quickly that a lot of hearing care providers and their clinics did not have a great sort of, direct connection with a particular surgeon, right? And so, many times I would receive an email back or something. It's like, you're the first surgeon that's ever reached out to me in my 10 years of practice as an audiologist or something like that. And so I noticed that pretty early on. And so I made a point to really be available and to meet these providers where they are. And, we have a local Chicago, Illinois Academy of Audiology. Their meeting is in Naperville every year. So I've given talks there. Later this year, I'm giving a talk at the IHS meeting in September to a lot of hearing instrument specialists. So, these kind of things, I think, and again, we talked about visiting with audiology students in the Northwestern University Audiology School. Sort of at various different levels, there's ways in which we can communicate and network.
Great. And so you mentioned barriers a few minutes ago, kind of within the health system. I think we're all sort of familiar with that. But are there any other barriers that are common that get in the way or impede the relationship between hearing care providers and surgeons?
Yeah, you know, um, I think one of the biggest barriers is the possibility that if they refer somebody for medical or surgical care, that they're going to somehow lose that patient, right? And so that is something that I'm very, very explicit about and very upfront about. That after I see this patient, if they simply just need continued amplification of any kind, then we send them back, right? This is, at least, this is how we care ourselves, and this is how we value our professional relationships with our referring providers. So I think being really upfront with that, is very helpful, because I think that is one considerable barrier, right? People don't want to lose their patients to some other clinic, and then never hear from them again, right? And so, I always tell my referring providers that I'll send you a note with my clinic visit. I'll fax you a note, and with what I think, and certainly if there's more discussion to be had, I'll call you or I'll text you or something like that to let you know, keep you in the loop. And I think people certainly appreciate that. I certainly appreciate that when I refer to somebody else, and they do the same for me, about patients that I send away. So I think that is one barrier, but I think that can also be easily addressed. So.
Excellent. Um, let's talk about on the flip side, what are the benefits of a really close or effective relationship between the CI surgeon and say maybe the audiologist? Benefit for
Yeah, I mean, it's such a wonder. I mean, listen, we're all in this to help patients with ear and hearing problems, right? And I think, and rapid communication and good communication is the key to getting patients seen by both providers, right? And this is such a multidisciplinary field. It's incumbent upon us to really work together and work together well. From a medical and surgical side, obviously, I can get patients in that need to be seen urgently, very quickly into my clinic. But also, at the same time, uh, these are, I work with some outstanding providers that also provide, for example, tinnitus retraining therapy and hyperacusis therapy and misophonia care, and I rely on them to help take care of the patients that I don't know how to manage very well. And so, some providers also, at Northwestern, we don't accept third party insurance for hearing aids, and so we need patients. It's amazing to have really good connections so that we can send those patients to providers that I know I can trust, that accept those insurance benefits, to take care of those patients. So it's definitely a two-way relationship, and there are, and so, I mean, it's but like in the realm of cochlear implants, for example, that's a patient that keeps coming back to you as a hearing care professional, and they're still unhappy with their hearing aids, and you've done the best you possibly can do, and it can be frustrating for both the patient and the provider, right? So, if we get them their cochlear implant, they're hearing better, uh, that's just another person that's helped, and somebody else new that can see that provider as well, instead of having to sort of deal with the same frustrations over and over again, because you're sort of at your limit of what you can do. So.
exactly. What advice would you give to a hearing care professional who's looking to build a stronger relationship with a CI surgeon?
Yeah, I think, one of the things that, so first of all, the advice is that there are these sort of barriers that exist, especially with major health systems. But it doesn't have to be that way. And so, it can, it goes both directions, right? I can certainly reach out to hearing care professionals, and vice versa as well. Because ultimately it leads to faster and more efficient and better patient care, right? And so that's one thing is there are barriers in place when it comes to scheduling, and we've all sort of experienced this as patients ourselves when we're trying to schedule a visit, and it can be kind of challenging unless you know somebody, in that health system or something like that, that can get you in quicker. And so it doesn't have to be that way, right? So that's sort of issue number one. But I always, when we talk to young surgeons as well who are just starting to build their practice, like me, for example, um, while I am very, very motivated and passionate about cochlear implant care, you don't I mean, these kind of relationships, these kind of professional relationships are beneficial even if you aren't as passionate as I am about cochlear implant care, right? Because these are ultimately patients with hearing loss problems. And, I have had multiple patients come in from audiologists and hearing care providers that have had vestibular schwannomas and otosclerosis and, bad draining ears and or severely impacted wax and, all sorts of stuff that help to, those are patients that need medical and surgical care, in addition to, cochlear implants, for example. So this is really sort of at the fundamentals of building a practice, for both parties. And I think it just, at least it's just so helpful, to have these relationships, going forward.
Another question I have kind of along the same lines. I'm curious to know, how does early involvement of the audiologist in the treatment plan, how does that impact surgical outcomes?
Yeah, so it's extremely, extremely important, right? So, I mean, you know, I mean, pretty much if you want to be seen in my clinic, almost everybody needs to have a hearing test for what I provide, for the kind of care I provide. And so if you are, you already come in with a hearing test, that just gets you in quicker, right? Because sometimes we're limited with how many hearing tests we can do in a day, or our audiologists are also doing other things. And if I need an add-on audio or something like that at the last second, it may not be possible. So for someone who's already had that done, and my referring providers, they know when to refer patients and what's appropriate, and so their involvement early, they've already done all the hard work, and now it's my job to sort of take to take the baton, and to move on to the next step of medical or surgical care. So they're already, their early involvement is the first step of all of this care, and a lot of times it can get patients in a lot quicker simply because they already have all the testing information they need, or at least a key and critical piece of it. Which the limitation might be on our end in terms of our booth space availability and a number of diagnostic audiograms we can perform in a day. Again, it's really helpful when all of this is already in place. And a lot, I have also other, audiologists I've worked with that, you know, they have been, you know, they have been working on their patients for months or years trying to talk them into getting a cochlear implant because they know how much it would help them. And so it's all of that effort, it's all of that work that they've done with their own patients and their relationship with their patients that's really made my job so much easier when they come to me, right? And so I really value them and cherish that.
That I have two questions, two follow-up questions that stem from what you just said. The first is, what specifically, now we can get a little weeds in audiology here. When somebody comes in with an audiogram, what specific tests are you looking for? Like, obviously pure tones, but like what speed tests do you look for? What do you say? Oh, they don't have it here. I got to get this done while they're in the office and try to work them in.
Yeah, so I would say, basics of stuff that I need, and I think any ENT provider or otologist, neurotologist would probably need, or basic pure tonometry, pure tone audiometry, speech audiometry, speech information, speech testing, and then tympanometry, and then also for me personally, I only need acoustic reflexes only when someone has a conductive hearing loss and they have a normal tympanogram. That's pretty much the only time I ever need acoustic reflexes. And really what I'm looking for, right, is otosclerosis versus superior canal dehiscence. I don't really use acoustic reflexes in the setting of asymmetrical hearing loss or those kind of things. That's my personal practice preference. A lot of these patients are with a significant asymmetry are getting an MRI anyway, and that's a lot more effective than acoustics reflexes. So.
Exactly. It makes sense. It makes sense. And my second question is, um, what what advice would you give an audiologist who's trying to persuade a patient to come in to get a CI evaluation? What should they say to
Yeah,
the person to motivate them into action?
yeah. I mean, I think, well, so that's a really great question. I think where this comes from is how comfortable that audiologist already feels about the counseling, right? And so I think if you are an audiologist and you've been in practice for many, many, many years and you're not sort of up to date on the counseling, then it's going to be tough, right? Like they don't perform surgery, like they don't perform these, procedures. And it might be kind of, it might be tough to talk about, oh, the procedure is this from that, or it's, but the truth is cochlear implant surgery is now so standardized and it's so consistent across surgeons, I believe, especially high volume surgeons, um, that you can pretty much say there are, at least when I work with referring providers, I tell them, please feel free to say these things, right? Things like this is outpatient surgery, takes about an hour and a half to do under general anesthesia typically. It's a small incision behind the ear, you know, because the majority of patients, I think, or a lot of patients are just terrified of the procedure itself, right? Like this is a big surgery. I think if you use phrases like, the surgeon's gonna drill a hole in your skull, right? Like that's not gonna that nobody wants to hear that. Nobody wants to do that, right? And so, or if they're told that this is brain surgery, it's near the brain, right? Those are, in my opinion, misinformation, right? Because this has nothing to do with the brain. And so I think it just comes down to how the counseling might be if the surgery itself is the primary reason why they're afraid of going in for evaluation, right?
Mhm.
Um, if we're talking about audiometric criteria and those kind of things, I think, again, some of the counseling too, and how much they already are aware, well, nowadays we are implanting patients with almost normal, sometimes normal low frequency hearing and just precipitously dropping high frequency hearing or middle and high frequency hearing with poor speech discrimination. But those are candidates. Those are actually excellent candidates, right? You don't have to be, no response on everything anymore to be a candidate for a cochlear implant. You don't have to be so completely deaf. Obviously, knowing that you can be one-sided deaf, or with significant hearing loss and be a candidate for cochlear implant. It's just a lot of, I think, education, and the ones that are pretty up to date with everything and feel comfortable saying some of these things that I've talked about. I think it's probably easier for them to get their patients to come in. Again, just, and then, also now we're finding that, there's really no age limit too, really, as far as the upper end is concerned. I mean, we've had great success with people in their 80s, 90s, even, people that are just have a vigor for life and are healthy and just want to hear better and communicate better with their loved ones and family and friends. If they're, healthy enough for a brief general anesthesia, they're going to be fine, right? So, but these are sort of newer, depending on, how out of the game you are or something, newer concepts. And it's just, it's important for us in the cochlear implant community to spread the word and educate providers on how we're doing things now.
Well, I see our time is winding down. Any final thoughts? Any other advice that you'd want to share with possible CI candidates, with audiologists, with hearing care providers?
Yeah, I think, I mean, obviously biased, right? I think cochlear implants are amazing, that we can, restore hearing to patients that have lost it. But remember, just going in for an evaluation doesn't mean you're getting surgery, right? This is ultimately the boss is the patient, and it's their decision. I think having the evaluation is really helpful just to sort of quantify how good or bad you're currently hearing. And while we don't have a magic wand or to be able to, or a crystal ball to be able to predict how well you're going to do with a cochlear implant, right? We can at least provide some averages. And if you are way, way, way below average already starting out, then you might be a really good candidate for a cochlear implant, because even if you get just average scores, you're doing a lot better than you currently are. I think when it comes to, um, sort of what we've talked about in the first half of this is relationship building and professionalism or professional networks. I think, this, working together in this way and being, having good communication and reaching out, can be so rewarding for you as an individual and provider, but also, but certainly for your patients. And I know that's certainly been the case for me, in my practice and how it's grown. And so, um, the worst thing that can happen is someone says no, right? So I think it's just been rewarding to reach out and do this outreach and get to know the community providers. So
Great. Do you have a website or some other place that you would direct people to if they wanted more information about your practice or um, Northwestern's implant program in general?
yeah, so our, cochlear implant, or our Northwestern Medicine cochlear implant, website is nm.org, backslash cochlear implants with an S. So that's a nice link for them, and obviously, if you Google my name, you can find me, in the, with Northwestern especially, then you can find me in if you're in the Chicagoland area. Yes.
Excellent. And we'll post that on the bottom of the screen too. So, um, thank you very much, Dr. Kevin Zahn, Assistant Professor of Otolaryngology and the Director of the Northwestern Medicine Cochlear Implant Program. Thanks for your time and expertise. We really appreciate it.
Really great to be here. Thank you so much, Brian.